Okay, good morning, everybody, and welcome and thank you for joining us today for the World Heart Federation Heart Cafe. My name is Jeremiah Mwangi. I'm the Director of Policy and Advocacy at the World Heart Federation, based in Geneva, Switzerland. Just a quick introduction to WHF. We're an association of national cardiology societies and heart foundations, and one of our main roles is to represent the cardiovascular community in Geneva with the global health organizations like the World Health Organization and so forth, and really to elevate the topic of cardiovascular disease in global health discussions, in addition to working with our members around the world. We are joined by a great panel today to discuss addressing the nexus of air pollution, climate change, and its impact on heart health. We will hear about the impact of air pollution and climate change on cardiovascular health, the scale of the problem, the role of cardiologists, and particular in terms of advocacy and outreach and with their patients. This is a topic which, frankly, I think should concern all of us. The WHO says that almost all of the world's population, 99%, at some point are breathing air that doesn't meet the minimum requirements for air quality and contains pollutants. If that's the case, what's this doing to our bodies? What's this doing in terms of cardiovascular health? And how do we address that? So we have a very eminent group of experts with experience in this field who I hope will be able to shed some light on the burden, the impact of air quality, air pollution and climate change, and also to share some ideas about what we can do about it, how as a cardiovascular community we should connect and address this topic. So joining us on the panel today we have Professor Prabhakaran Doraj, who's the Director of the Center for Chronic Disease Control at the Public Health Foundation of India, Dr. Sadir Al-Kindi, who's a cardiologist and director of the Center for Integrated and Novel Approaches in Vascular Metabolic Disease, the University Hospital's Harrington Heart and Vascular Institute, Dr. Janet Wright from the Division for Heart Disease and Stroke Prevention, Center for Disease Control and Prevention, and last but not least, Dr. Colin Phillips, the chair of the American College of Cardiology Climate Change Task Force. So I'll ask a few questions of the panelists, and then I'd like to open it up to the audience for discussion and questions. And I'd like to start first with you, Professor Prabhakaran, and just to really give us some insights on how does climate change and air pollution affect heart disease, and how robust is the evidence?
Right. Thank you, Jeremiah, and I'm very grateful for all of you being here. Are you able to hear me clearly? Okay, right, thank you. So air pollution and climate change act in myriad ways in terms of increasing cardiovascular risk and cardiovascular mortality. In terms of air pollution, we have several markers like particulate matter 2.5, nitric oxide, sulfur dioxide, ozone, black carbon, and several others, gaseous substances. So what it does is it acts in three different ways. One, it produces endothelial dysfunction and stiffening of the arteries, resulting in hypertension and such other problems. It increases inflammation. It also is responsible for increasing the sympathetic milieu. So there's sympathetic overactivity. In addition, it can directly affect the heart. So there are multiple mechanisms by which air pollution can act, because the PM 2.5, to give a perspective, is a very, very tiny particle. Just to compare it to human air, it's 1/70th the size of a human air, and it can cross the alveolar blood barrier. It's half the size of an RBC, so it really can cross once it crosses, it produces these cascading effects. Climate change is somewhat indirect. It produces extremes of temperature. It can cause variable humidity, making even if the temperature is okay, it becomes uncomfortable. It can cause flooding. It can cause droughts in multiple places, and therefore it actually results in food insecurity. It affects the food system, and it affects the agricultural production. And we now know that cardiovascular disease spans the life course. If you have maternal undernutrition, childhood undernutrition, it can result in higher risk for cardiovascular disease. So climate change is somewhat indirect. And for people with existing cardiovascular disease, floods or drought can actually impact their care with huge floods. This happened in Chennai recently. A lot of people couldn't go to the hospital for cardiac rehabilitation or to get their medicines, and so they skip medicines and result in complications. So it's both direct as well as indirect.
Thank you. And could you say a little bit about the state of the evidence in terms of the link between both air quality and climate change and cardiovascular?
It's interesting that you asked this question, because when you look at the number of people who die due to air pollution, it's said that close to 7 million people die because of air pollution in the world, which is something like 10% of the total deaths that occur every year. But when you ask any group, even the group here, the cardiologists, what do you think air pollution causes? They will say respiratory illness. They will say childhood asthma. They will say childhood pneumonia. Sometimes they'll say lung cancer. But if you look at the proportion of deaths, 33% of the deaths is due to acute myocardial infarction. And then if you add stroke, 20% of the deaths by air pollution is stroke. So 50% of the air pollution related deaths are because of cardiovascular diseases. And the big problem is most of these deaths are premature. It occurs, just to give a perspective, in countries which have high levels of air pollution such as India, the proportion of premature mortality is pretty high. In fact, 52% of the deaths in India due to NCDs occur before the age of 70 years, whereas it's only around 15 to 20% in high income countries. So the loss is much larger, despite the number of deaths, much larger in low middle income countries, because people are dying young, they're dying during their productive years. But despite this fact, there's a lot of skepticism about the evidence. The problem is because it's easy for us to relate, say, blood pressure to future cardiovascular mortality because it's inherently present in that person. How do we assign, say, for example, PM2.5 value to a given individual? How do we measure this? Obviously, we cannot give them monitors to carry around and we measure. So it's going to be very difficult. So we have to model. And there are various modeling techniques. Most people use the satellite data and obtain the values of PM2.5. But there are more robust methods which we are working on, which includes looking at emission inventories, looking at monitoring stations, adjusting for land use, adjusting for meteorological variables such as, because PM2.5 is not static, it can change. Like I've been watching Atlanta's PM2.5 for the last 4 days. It's varied anywhere between 20 to 85. Today, right now it's 63. So it's pretty high. It's as bad as what Delhi has now. So it clearly keeps changing because of the meteorological. So you have to adjust for that. You have to adjust for the transport network, density of the population, and several others. So using those kind of models and getting a narrower grid of 1 kilometer into 1 kilometer, we can assign that exposure. Second is the outcome. For outcome assessment, you require good, well done longitudinal studies, which are very far and few in low middle income countries. There are several in United States and European countries, but in low middle income countries they are very far and few. So in that sense, we have established a cohort and we have kind of shown that link, because the governments, the policy makers demand that evidence. They say, where is the evidence? These are all Western evidence. And it's whatever evidences that you have now are all cross-sectional. So you require cohorts. So this is the state of what we have right now in terms of air pollution in most parts of the world.
Thank you. If I could turn now to Dr. Wright. What are some of the trends being observed in the US and globally on the effects of climate change and air pollution on heart disease? And is this considered an area of concern by the CDC?
Thank you, and I appreciate being here today. Let me ask, can you hear me? Okay, great. I don't want to shout at you. Concise answers is things are going up for the worse everywhere. And yes, the CDC very much cares about it. I decided in a short period of time maybe what I might do, because I am not an expert in either of these areas, but I am a cardiologist, and I believe that each of us has an enormously important role to play. So I'm going to sort of walk you through personal experiences with air pollution and climate change as just a marker for how quickly this is changing. I have had a long life, but so let me try this. I grew up in a small town in Arkansas, where on the Arkansas side of the Mississippi River, periodically the Mississippi would flood. And I remember my grade school classmates and I doing science experiments where we basically faked a flood, and it was a good thing because we all thought it enriched the soil, the alluvial plain, if you will. Now we know that floods, only just in the U.S., are killing about 100 people per year and affecting multiple states. It is not a good thing for the soil and the farmland. It's taking away our farmland. I moved to Northern California in the mid-'80s, and at that time, periodically, there would be wildfires, periodically. Those increased in frequency over the 23 years of my practice, as did the heat in the summer. It was already hot when I moved there, and it got hotter and hotter over that 23 years. By the time, the latter part of my stay there, around 2005 to 2008, the wildfires occurred every summer. And I still can't believe this looking back on it. As soon as we would see the light turn in the sky and the smoke start to penetrate our airspace, all of us, the cardiologists, my practice and others, and my respiratory therapist and pulmonologist friends just basically moved into the hospital. The classic sequence was people with respiratory illnesses started coming into the ED, respiratory distress, developed atrial fib, had an infarct, had a stroke, and we just saw this. First the EDs filled up, then the ICU filled up, and we were there. I didn't know at the time the pathophysiology that I now understand was causing those things, not to mention how we could mitigate the impact on our patients. I moved to DC in 2008, and 10 years later, the community where I largely practiced, Chico and Paradise in 2018 was laid waste by the Camp Fire. 14,000 homes, 86 people died. The community was scarred forever, both from the mental impact of the Camp Fire and the aftermath of the Camp Fire. And of course, you all know there were other additional fires in California that have followed. What we didn't know then are the things that we could do to mitigate this. While living in DC for the last 10 years, I got to know people on the Chesapeake who were literally raising their docks because of rising waters. Those docks that they had had for years were no longer at the right level because water levels were rising. I now live in Colorado. My first summer there was contaminated by wildfire smoke, everybody inside. And then my second December there, December of 2021, was the Boulder Fire, a fire in December. It took 1,000 homes, killed 2 people, and the investigation showed it was caused by a slash fire that was not adequately extinguished and an electrical wire that was left sparking in that community. This is Monday. On Saturday morning, well, actually on Friday, I started getting notices in Colorado about a high wind event that was to occur on Saturday for a 24-hour period. And on Saturday, I got a notice that the electricity would be cut to the communities where I live and the surrounding ones to prevent that sparking of electrical wires. To my knowledge, there were no fires during the high wind event, but yesterday morning I got a call from my neighbor because a dead tree had fallen as a result of the wind event, which could well have taken down the electrical wires in the neighborhood. My whole point in this trajectory is, from my childhood, adulthood, and on, all these things have increased in frequency just in the US. We now are beginning to understand how to mitigate the impact, what we can do individually and as communities, And as my colleague here has said, there are really specific things that as cardiologists and team members we can do to protect our patients. And we'll get to that in a moment. What I will say about CDC is CDC, as well as other, not just the heart disease and stroke part of CDC, but the environmental health part, our colleagues at NHLBI, our colleagues at EPA are all very much concerned about this and trying to put in place the research and the evidence that will help us mitigate that impact.
Thank you. So you mentioned something about, you kind of highlighted the vulnerability of some communities in terms of climate change and its impact on them. And actually I would like to turn to Dr. Al-Kindi, because it raises the question, what are some of the other socioeconomic risk factors that play a role in how vulnerable we are to air pollution and climate change, particularly in cardiovascular health?
Yeah, perfect. So I think let's just set the stage by talking about vulnerability and susceptibility. And these are oftentimes for the lay people, are used interchangeably, but they're actually meaning very different things. So vulnerability means that you have a community that's exposed to higher levels of air pollution versus another community that's exposed to low level of air pollution. And we have several examples in the United States and globally as well, as to some communities are more vulnerable to the exposure of air pollution. But susceptibility is a little different. Susceptibility means that there is something inherent, something internal, some biologic or genetic factor that makes you at higher risk, although you're exposed to the same level of PM2.5 or other exposures compared with another individual. So for the same amount of increase in PM2.5, let's say 10 microgram per meter cube, by moving from Colorado to California during a wildfire, you get a higher, if you're susceptible, then you get a higher impact with respect to cardiovascular or other health outcomes. So what does the literature say? What we know so far is the vast majority of studies have looked into singular or dual joint, what we call joint exposures, meaning that I look at PM2.5 in isolation. That's most of the epidemiologic studies, and interventional studies obviously look at reduction in one PM2.5, for example, sometimes ozone and whatnot, when you put portable air cleaners at home. So what do we know about the joint exposures is very little, and we just started to scratch the surface. So our own group studies have shown that there is significant interaction between intergenerational racism, for example, including redlining, right? This is something that is happening that happened in the United States and continues to have a long-lasting impact, and the susceptibility and the vulnerability to air pollution effect. And we see actually both in the United States, that people who live in red line neighborhoods where they've been exposed to intergenerational racism, health inequities, they are at both increased levels of exposures from various pollutants beyond PM2.5, but they're also at higher level of susceptibility. In general, what we do know is, from a biologic standpoint, aging and pre-existing cardiovascular disease or any health outcomes can potentiate the impact, so increases susceptibility. In general, some marginalized communities are also at increased susceptibility for air pollution, but we're starting to scratch the surface because there might be other co-pollutants and co-exposures. For example, you can imagine having noise on top of light, on top of PM2.5 can actually amplifies all of these exposures and their impact.
Thank you. I'll come back to what we can do in a little bit. I'd like to just hear from Dr. Phillips, just in terms of you were sharing with me earlier about some of the work that you're doing in your practice to educate and make people aware of air quality and climate change. But what are you observing directly in your practice in terms of the impact and changes in temperature, changes in air quality?
So thank you guys very much, and thank you all for being here. I'm a practicing interventional cardiologist in Portland, Maine, and so although we don't have terrible air quality in Maine, we do have days of bad air quality. And so as an interventionalist, I see the effects both acutely and chronically of bad air quality. So no question, on days when there is high temperature, wildfire smoke blowing in, we have more heart attacks. Can I prove it? No, but subjectively, clearly there's a relation there. And the providers all know it, and we kind of get ready on those days. And it is a risk multiplier for a vulnerable plaque. In Maine, traditionally we talk about snow shoveling triggering MIs, and now unfortunately we're having not just snow shoveling but bad air quality days triggering MIs. So acutely, poor air quality does affect the heart, but chronically we see it as well. I want to share a patient vignette. A patient that I've known for 5 years. He had an inferior defect on a nuclear study, exertional angina that was reliable, and sure enough he had a CTO of his right coronary artery. 5 years ago we opened it up. He did very well, but as a good patient he followed doctor's instructions, and he would walk and exercise. And so I recently saw him in clinic and asked him, well, what's going on? I mean, I'm reading in the chart that you keep having episodes of chest pain. When are you getting this chest pain? The right corner that we opened up shouldn't have gone down just yet. What's going on? And I was like, well, it's not always, but when I take this specific loop, I get the chest pain. And it's not every day, it's some days. And so we looked together on the map where he was walking, and sure enough, we have a lot of trees in Maine, but because we have a lot of trees, we also have paper mills. And so he was walking around a walking path around the paper mill, and on certain days when he could look on his phone, when the air quality index was poor, he was getting chest pain. And so I communicated with him, and we basically devised a strategy together about how to minimize his risk on days when the air quality is bad. Now there's things that he can control, things that he can't control, and certainly he can't really tell this company, or at least we haven't figured out a way for him to tell this company yet, please stop burning whatever you're burning, it's making things worse for us. But clearly he's having a chronic exposure that is affecting him and affecting his quality of life.
And in terms of coming up with the solution and a care plan and how to mitigate against the exposure that he's having, is there any systematic guidance or tools for that generally in practice, or how to consider that when working with your patients? Is this something you've just kind of reacted to and
Thank you,
developed?
Jeremiah, for the nice question. So obviously the work that we're doing is informed by the excellent work that scientists and public health officials and great programs like the Million Hearts program and the CDC and air quality, airnow.gov and all these other wonderful groups. So I'm one of the governors from the Board of Governors for the ACC, and to answer the question of what have we done, I invite you all to please grab this beautiful infographic that the ACC has put together. And it's basically, patients are looking to protect themselves, and patients are looking to live healthy lives. And so we convened a working group with the Board of Governors and came up, it was a group that was representative throughout the country, and we came up with ideas and strategies that we can use to inform patients, but also, by the way, to inform clinicians about the direct link between, which you've heard here already, between air quality and heart disease. And so this starts that conversation. This is a means of making it easy, because I do this, not as much as I should, but it is uncomfortable to have these conversations. And part of that is because we're not trained to do this. It's really easy to have a conversation about smoking. It's really hard to have a conversation about, well, where do you live and what are your exposures? I hope that this will help start that conversation and keep it going, because unfortunately, as you heard, this problem is not going away. But we can do better amongst our group. So again, thank you guys for being here. It turns out like 50 to 60% of cardiologists, practicing cardiologists that were surveyed, still don't know much about this linkage. And so it's things like this. And so thank you to the WHF and the ACC for sponsoring this. So
thank you. Before we move on a bit more to solutions and how we engage the cardiology community, I wanted to give an opportunity for questions just on the research and the evidence and data. So I just want to ask if the audience has any questions or points they'd like to raise. Please.
Thank you. So I'm Robin Bueno from the National Center for Complementary and Integrative Health. Was previously at NHLBI for almost 20 years, worked on the TAC study, which was positive for reducing cardiovascular endpoints. TAC2 was reported yesterday. It was negative. Why do we think it was negative? We looked at the NHANES data from the period of the TACT, where I think the mean levels were about 17 higher in the population. We looked at the data because we didn't have biosamples from the original study because we thought it was going to be negative. So we got samples for this TAC2, and in both NHANES, the mean had dropped down to 11 for lead and 9 in our population. And so the study did not show that there was a benefit. We think that may be because we've also seen from EPA reports that air quality has dropped since 2010, has improved about 60% less lead in the environment. So it's still early days. We need to explore this data set and what we've learned. We saw but both the lead level did drop in the people that were on the active treatment. So I just wanted to point that out. I think that's a sign that public health interventions, reducing lead in the environment, may be very important, and that showing that here in the U.S. and Canada, where the study sites were, may be helpful. I think that may be the most important message that we may end up with that study. The other thing I'm not hearing people say is that in 2023, there was Tony Lamas, the first author, Contaminant Metals as Cardiovascular Risk Factors, a scientific statement from AHA, saying that lead, cadmium, and arsenic are now considered cardiovascular risk factors. So you guys may not have come upon that. Tony was very disappointed it didn't get a lot of press at the time it came out. But I think it'd be really interesting to talk to some of you guys about some stuff maybe we could explore in our data set now that we've reported the results.
Thanks. Would anyone on the panel like to reflect on that briefly?
So thank you. I think the TACT and the TACT2 studies were fantastic demonstration of how can we impact environmental exposures, right? And yes, it's disappointing to see that there is no reduction in primary outcome, at least in TACT2, following a positive study in TACT. But still, I think it's a good information. It's a good scientific kind of discovery to understand, okay, first of all, things are improving over time, and perhaps the return on investment when things are improving is good. I would say that the pollutants, the air pollutants, are the opposite, right? Although the average PM 2.5, for example, exposure in the US is dropping, urbanization, people are moving towards more urbanization, becoming more susceptible because of the aging population. That is by itself causing an increasing number of events as an absolute number. Although the rates, the age-adjusted rates may drop over time, but the actual event rate, so selecting the right population, doing the right intervention might be interesting. And I would love to talk to you about TACT and see how we can understand PM 2.5 exposure within the context of the intervention, which can be done.
Thanks. I see another question here.
Yeah, thank you for a great presentation. A couple questions. One is, how can you be aware of the AQI wherever you are? Is there an app? Is there some kind of GPS that can tell you? And second question is, what's the overlap between cardiovascular effects and asthma effects of pollution?
Would you mind also introducing yourself?
Oh, sorry, I'm Joe Marine from Maryland.
Would anyone like to take that one?
Thank you, Dr. Marine. So just briefly, I mean, you can see it publicly available. It's a real-time updated thing that airnow.gov has, but airnow.gov can also speak to, I have no financial disclosures, but many of us have phones, and if you look at your weather app, hidden in there is your air quality index as well. And so it is something, some days you bring an umbrella for rain. Other days you should consider modifying your behaviors based on your risk that we were hearing about and what the actual air quality level is. So,
thank you.
I might add that there is a heat index indicator that is now available in California, but will soon go nationwide. That will help also, it's very similar to the air quality, will help us predict what the heat index will be each day.
Question in the front.
Yeah, hi, Drew from Michigan. So I don't know if you guys are going to be talking about this, but with home purifiers, has there been any research as to how effective they are? And if they are effective, would you guys recommend that for certain populations?
So, very excellent question. I think there is lots of literature, emerging literature, to suggest that packs or portable air cleaners, specifically with HEPA filters. These are filters that are filtering the very tiny, there's 95 and 99. But the idea is, we know that they're very effective at reducing PM levels. So they're approximately 95% effective in the real world to reduce PM levels. But remember, these are only done in the confined setting of the home, for example. There is randomized trials, believe it or not, many randomized trials. Most of them are done in the US and North America, but there are some done in China and in India, where you randomize patients who have hypertension, for example, to a HEPA filter or sham filter. So people don't know, it's completely blinded, everybody's blinded, and you see a significant reduction in systolic and diastolic blood pressure, specifically in those who are obese. So we know that it's effective. We know that short-term studies up to 2 weeks have shown that it's effective in reducing blood pressure as well. And there is also additional studies that show that there is improvement in biomarkers. What we don't know is whether it's effective in clinical outcomes and how durable that impact is, right? And that's something that, collaboration with NIH, needs to be some multi-center study similar to TACT, where we can actually understand this impact, because these portable air cleaners are cheap, right? They're $40, $20, $30 that you can put in someone's home, and if you put it in the bedroom when people are sleeping, that can reduce PM 2.5, the average PM 2.5 for the entire day, by approximately 60 to 50%. So you get significant reduction in PM 2.5. So it's all about choosing the right areas, right? Choosing the right patients and doing the right intervention to understand durable clinical outcome reduction.
So I just wanted to share our experience in India, because most of the studies, as you rightly pointed out, are coming from the West. There's actually one study from Mongolia which has shown that if you give air purifiers to pregnant women, this was done in a higher socioeconomic status, the birth weight increased by around 40 grams or so, which is big actually. But what we are doing is, we are doing a randomized controlled trial of low-cost air purifiers, but with a specialized HEPA filter, which is much more advanced than the regular HEPA filter. It reduces PM 2.5 by almost 95%. So in our pilot data, we see that from around 150 to 200, it comes down to 15, between 5 and 15 in that given room. If they don't open the windows and don't open the doors frequently, it actually stays that. So what we are doing is, we are randomizing patients of heart failure, HFrEF, into two groups, one getting the advanced air purifier, the other getting a sham purifier, which just filters out dust and bacteria. So we just want to look at what's the quality of life, 6-minute walk test, and in secondary outcomes, we are looking at change in mortality, because the mortality in India after heart failure is very high. It's almost 50% at 3 years. So though it's a secondary outcome, there's enough power to detect a difference. The study is just begun, so we will get the data in around two years. We will give this intervention for 1 year totally, because we want to cover all the seasons.
Please.
Put 2 cents in here. The EPA has a video on how to make your own air filter at home using a box fan, a very low cost investment, and easy to access on their site.
Just wanted to add, this air filter will cost $100. We're trying to reduce the cost further.
And one more little plug on the CardioSmart website, the online version of this, we have links on how you can build, from the EPA website, how you can build your own air purifier. Just a quick comment. I'm obviously an interventionalist. We treat acute things, and it's always like, well, we're opening up the blocked artery. But sometimes we do need to think about what is it that caused that blocked artery. And it does feel like when we're answering the question of, well, there's bad air quality, how are we going to improve that? Well, let's burn more energy to fire up a air purifier to help. And no question, it helps, and I'm eager to see the data. But at some point, we do need to ask ourselves the preventative question of, can we just stop burning energy, and how can we limit our fossil fuel consumption, which truly is the root of all of this, and what can we do to help, the generations beyond us going forward? Because again, there are band-aids, but we need long-term durable solutions as well for this.
An excellent point. Another question at the front, please.
Hi, Ralph Brindis, San Francisco. Building on that very point, what is our role as healthcare providers, nationally, locally, hospital-wise, hospital systems, and at a physician level, to mitigate the effect of climate change? For example, the National Academy of Medicine has become very interested in looking at best practices in hospitals, whether it be solar system on your or whatever. Also, all the waste that we have. Anybody want to comment on our role in healthcare in mitigating climate change?
Like, I can take that actually. So I think we can look at it at two levels. One, as individuals, what can we do? And as at a health system level, what can we do? At an individual level, I think we are a very powerful community, and we can become advocates for change. We need to create the awareness in our own community amongst the doctors as well as amongst our patients. That's number one. Second, I think we should become lobbyists for intervention by policymakers. And this is very important because there's a lot of resistance to any intervention in climate change. Your elections are going to come in the next few years, and you will see what happens subsequently. So you need to be constantly on the vigil and advocate. The health system is very important. It's estimated that 5% of the greenhouse gases in the world are emitted by the health system. And if they were to be a country, it would be the size of France. So that's the amount of greenhouse gas emission by the health system. And there are simple things that we can do in terms of reducing these greenhouse gas emissions. Example is waste disposal. If you have proper waste disposal in the hospitals, in many parts of the world it's not there. We need to have a standardized waste disposal mechanism. Second, anesthetic gases. So even a slight decrease in the use of anesthetic gases can reduce, because there's a leak, and that can reduce greenhouse gases. Second, the third is sustainable procurement. How do you procure your equipments? How do you procure the drugs? And what are the things that you use? Can we change the gloves to a more sustainable form of gloves from latex to some other thing? There are many things that can be done. And this awareness is really required in terms of the health system change that we can do, and it can go a long way in reducing. So as doctors and as health system professionals, we have a huge role in combating climate change and air pollution.
Please, Dr. Wright.
I love everything you said, and Ralph, I appreciate your question. I will say two things. One is vote. Let me just say that again. Vote. Get all your family members to vote. But the second thing is I'll point you to some resources related to health systems. Million Hearts collaborated with an office in the Department of Health and Human Services with the EPA in a series of webinars that were focused on health professionals and health systems and the specific things that they can do to limit their footprint and to improve the processes that they have, all the way down to the details about idling when big trucks are offloading supplies and how damaging idling can be, but all the way through policies that can be enacted through their relationships with vendors, but also within the institution itself, some of which my colleague mentioned. So all those webinars were recorded. They're all free. They're on the Million Hearts website, and they come with slide decks. You can get through it really quickly from an audio or a visual standpoint.
Thank you. I'm curious, and I'd like to ask Dr. Phillips a question, just specifically relating to ACC and your expert group on climate change, or the working group, I should say. Do you see a role for ACC in lobbying for policies that are more friendly to this agenda? And within the ACC and the community, have you done any studies or assessments of the knowledge and awareness of the impacts of climate change and air quality on cardiovascular health?
Now that question's a lot harder. So, I mean, honestly, anyone in the audience has any ideas, I'm open. That's a very challenging question. I think, you know, as the ACC, our strength is in the science, and our strength is in direct connection with patients. And so that, you know, the idea of this infographic was to start the conversation that will hopefully lead to bigger questions about what policy changes will be effective at protecting all of us going forward. And so I can speak to a little bit of experience, again, on Dr. Brindis's question. For advocacy at a local level, it's helpful to have something like this infographic to bring to our city council. I've with my wife, done some local advocacy work, and it's slow going. It seems like it's a lot easier to sort of create trouble than it is to fix trouble. But having the ACC and having the backing and the mark of you know, the science is important. And I think, you know, there are things that we disagree on, there are things that we can agree on, and the science usually cuts through a lot of the things that may be more controversial.
Yeah.
I mean, you would think this shouldn't be controversial, but it very much is.
Mm-hmm.
And so it's a community effort. It involves all of you to be involved in this. So, not sure if that's the perfect answer for that.
No. Great answer. Thank you. I'd like to turn back to Dr. Sadir. While we're on the topic of policy and advocacy, what are some of the steps that need to be taken at the policy level to help protect against or prevent the negative effects of climate?
Yeah, and I think this is something that's very complex, as was alluded to, and I think it depends on how we want to start, right? And I think everything has to be in parallel, right? There must be parallel interventions at every, you know, at the individual level, at the societal level, at the policy level, at the federal level, and at the globe as well. Things that are related to cardiologists, I think environmental sustainability of healthcare is key, and I'm seeing more and more organizations assigning chief sustainability officers, for example, as part of their ESG kind of transitions, and making sure that we understand what is the carbon footprint for my hospital, what are the sources of the carbon footprint, right? What are some of the things that we can understand to reduce, you know, understanding the problem first, understanding the sources first, and then trying to fix them. And there has been some successful examples from around the world where there are some, you know, small interventions like plastic, recycling. There is some additional waste recycling. There's even sometimes related to device recycling, right? So you're reutilizing some of the stents that are, you know, close to expiration, or even explanting ICDs and pacemakers from deceased individuals, and, you know, sterilizing them and implanting them in individuals who may not be able to afford them in developing countries. So there are ways to start to think about this. I think the challenge is twofold. I mean, there's multiple challenges, obviously, but there's a political challenge, and it's hard because you got to spend some money to gain, right? And it's like thinking about, you know, you're buying. I have no disclosures or relationship to electrical vehicles, but you got to spend more to protect, right? And what is the incentive to spend more to protect the environment? So in my opinion, it's a losing battle if you just go for the environment, because people are so focused on cost and healthcare quality, and you don't want to budge on both. But co-packaging it as part of some of the quality metrics, for example, might be helpful. So one example could be that if we were to list environmental footprint, if we're able to measure it accurately and list it as part of the US News listing or ranking, that might be a very powerful strategy for hospitals to report their exposures. For example, if we can publicly measure and report for each hospital, consumers might be, the environmentally savvy ones may choose one organization versus the other because it's a little bit more greener. So there are some scenarios, but this needs to be investigated because we don't want to have an unintended consequences for, you know, a haphazard kind of intervention that may lead to either increased cost or worsen healthcare outcomes.
Thank you. Professor Prabhakar?
I think this is a very important question in terms of how do we influence policymakers. It's a very, very complex scenario. One of the things that is really required is that we need to understand this is a multidisciplinary framework. It cannot happen within the ministries of health, but we require a dialogue with Ministry of Energy, Ministry of Forest, Labor, Commerce, Finance. So there requires to be a kind of coordination mechanism. In India, there's a push for that under the Prime Minister's office to do this. But the second thing is everybody is talking about their own national interests or local interests. Like for example, when we talk about coal-fired thermal power plants and stop banishing them, the problem is in countries like India, it gives employment to millions of people. How do you suddenly stop them? And second is, what is the metrics of measurement of air pollution or climate change? If you use the per capita mechanism, we are very low in the world. If you use the absolute number, we may be number 3 or number 4. I mean, US and China are the highest now. So what metrics do you use? So you require to have that kind of an understanding. The third thing is, the problem is we create return of investment studies. Suppose you invest in clean fuel, changes in transport, what would be the gain? But most of the studies are flawed and we give wrong information, and that is actually counterproductive. So we require some kind of robust mechanisms in terms of doing this return of investment studies.
Thank you. Dr. Rai?
Thank you. When I think about policy and the steps, I think about the evidence, and we've talked about we really need additional evidence about what works. And what we've seen over and over again with policies is if we don't think about the implementation of the policy at the time the policy is designed, there's inadequate execution. And so, again, thinking about that, the next step for me is translating what we've learned and making sure that we're translating it to the people that can take the action. An example is in the early days of Million Hearts, we wanted to include air pollution, but didn't really understand what people knew and what might be helpful. And as my colleague Dr. Phillips has said, awareness is still low, even among cardiology teams. And so we worked on awareness just about PM 2.5 and found that our cardiac rehab partners were the best ones to get that message translated to a very high-risk population. And so we transmitted to cardiac rehab through a collaborative a lot of information about PM 2.5 and feel that they are now really, they're on the front lines and can help reach that population. I'm intrigued with the idea of quality measurement, and could you envision a world where a condition of participation in Medicare is that your institution abides by a set of policies that make it a healthier environment? Now that's a big step. That would take a while to enact, but that would be a use of policy that might move the needle, at least for health systems.
Thank you. I want to give the audience again an opportunity for questions. Are there any further, please?
Hi, hello everyone. My name is Hua and I come from Emory University. So actually, my background, like we are environmental health people. So that's why I have some questions is, can you clinical doctors comment some of the future research barriers about climate change to CVD disease? So maybe I can give some examples. For example, wildfire to CVD. So right now, we see a lot of effects, but now there are also, we are wondering is that people actually smile of the high PM 2.5 in wildfire, or actually because people actually see of the fire? So what is the pathway? Or maybe on the other hand is talking about the built environment. For example, we know if people exposed to higher NDVI, the greenness, but also how could we really build those places, the greenness morphology affects people? Or maybe for air pollution to CVD. So before we are measuring the daily exposures, but now we can go to hourly, to actually identify the acute window. So actually it's but but I want to know is like as clinical doctors, like which directions you guys really care about, because those are all the possible directions we can go. But what you think actually are more urgent for clinical doctors to worry about or like to see the results? Thank you.
Yeah, thank you. This is an excellent question, and I think thinking about exposures and climate change and environmental pollution and environmental exposures, it's a lot, right? So, and not everything is created equal, right? When we think about PM 2.5, it's different from noise, different from light, different from temperature, right? So there's a lot of avenues to actually, understand the exposure's impact using epidemiologic studies, right? There is still a lot of unknowns, right? And understanding what is the impact of light pollution at night on circadian rhythm and how does it impact cardiovascular disease health. So a lot of evidence that is needed still. We're still just scratching the surface. I think PM 2.5 is probably the most studied air pollutant with respect to cardiovascular health outcomes. Although the data although it's very strong, we don't know exactly how does it impact other cardiovascular outcomes. So traditionally it's been linked with MI, stroke, and atherosclerotic disease. We still, for example, don't know whether it impacts heart failure outcomes to a certain degree. We know there is some studies, but we don't know whether it's causal or no, right? We don't know how does it impact atrial fibrillation. So there is evidence that's needed from an epi standpoint. And the areas that we've proven, right, both animal, human, and epi studies, like in the example of PM 2.5, we need to advance the field with respect to implementation of some of the intervention studies. For example, portable air cleaners, the impact of N95 masks, the impact of even AQI, right, air quality index. We've never studied whether introduction of air quality index to people can change their behavior, right? Does it change? So we need to move to an implementation type of studies where we can understand the impact of interventions in these arenas to understand how does it impact health. So there is a lot, but the challenge is always, as clinicians, we're not trained a lot of us are not trained in understanding the exposures as much, or even assessing the exposures. We're very good at doing clinical trials, right? And that's where I think the next, hopefully, couple of decades, we're going to do more of interventional studies similar to TACT, but with respect to other pollutants.
Thank you. I think I saw another hand up.
Thank you. Ashish from Kansas City Heart Rhythm Institute. So I just want to say I really appreciate the discussion. I think it was a great discussion. And I think there was one thing that really resonated with me that kind of builds off this last question, is that we still don't have a lot of the baseline understanding of the, how physicians feel about climate change and so forth. And so one thing, this is kind of like a little pitch. On some of the tables in the lounge areas, there's a little QR code for a survey, because that's something we're actually looking at as part of a hopefully grassroots effort. So if everyone can, if you get like 4 minutes of your time, we'd really appreciate it if you could fill out the survey, because that I think can help build some of the understanding about what physicians are currently doing, and then give us that baseline foundational information like we talked about, and how we can move to interventional studies. So.
Thank you. Before we wrap up, I want to give all the panelists a chance to share a final thought with us. And I was thinking that we've been talking about both the individual level and the institutional level. And I'd just be interested to know kind of what you see as a key priority or a takeaway for the audience that we can go away and do, both in terms as individuals, but in our contribution to the bigger ask of how we see health system change and policy change. So if I could start at that end with Professor Prabhakaran, if you could share a thought.
Thank you, Jeremiah. So I think what are the key takeaways for us? Number one is climate change, air pollution, environmental pollutants affects everybody. That's the first thing. We cannot say like I'm living in Boston, my average temperature is say 10 degrees or 40 degrees or 45 degrees Fahrenheit, it goes by 5 degrees extra, nothing is going to happen to me. The point is, we have seen that even in areas where the temperatures are not very high, if you go beyond your 97th percentile, the mortality increases, even in those areas. So I think clearly it affects everybody. Number two is we need to take a life course approach. We cannot focus only on adult cardiovascular disease, but we need to start from birth till death, because air pollution appears to affect cardiovascular risk across the lifespan. That's the second issue. The third issue is we need to take a systems approach rather than a siloed, disease-based or domain-based approach. You require system-level interventions, and at a policy level, you require multidisciplinary approaches or a transdisciplinary approach, if I may, rather than each person trying to. It's like the seven blind men trying to describe an elephant. I think all of them need to get together. And lastly, I think we need mitigation strategies. We now have the knowledge that it works, like as Von Goethe said, knowing is not enough, we should be willing. Willing is not enough, we should act, and it's time to act.
Thank you. Dr. Wright?
That's beautiful. I almost forgot I was next because I was thinking about what you were saying. So I would just continue that theme and say identify an action you can take as an individual, and then figure out what your community is. How can you group together? I can tell you federal agencies are beginning to work together on this with complementary assets. I would also let you know there are lots of available resources on any of the federal agencies that I've mentioned, the EPA, the National Center for Environmental Health at CDC, and Million Hearts. Lots of practical tools that you can use. I'll also ask you to stay tuned. In a couple of weeks, CDC is going to release additional guidance that has to do with heat and cardiovascular health.
Thank you. Dr. Alkindi?
Yeah, I think for us clinicians, when we think about educating our patients and doing interventions for our patients, it starts from within, right? So how do we achieve net zero carbon emission in our homes, in our families, right? I think that's how it starts, assessing your environmental exposures, and that could be done fairly easy with AQI, and familiarize yourself with some of the exposure metrics and so on and so forth, but also try to achieve what you can with the resources that you have to reduce your carbon footprint. I think that would be key, because otherwise you cannot preach this without having achieved this internally.
Thank you. And Dr. Phillips?
Thank you. I think you guys are doing it right now by being here. These are hard conversations to have. One more final plug for the infographic. Please bring this to your clinics and have the conversation, because it's not easy, and it can be very daunting to look around and realize that we're having a good conversation now, but this needs to continue going forward, and the data is there. I mean, we can always improve and make the data better, but it is awfully compelling, and we haven't even talked about micro and nanoplastics yet, and that's the next sort of layer of this ongoing disaster. But we got into medicine to help people, and we got into medicine because we're forward-looking, optimistic people, and this is our no bigger calling than to help solve this problem. So please take this back to your communities and to your patients and to your legislators, because ultimately we are only as safe as our laws make us.
Thank you. I think the final comments from our panelists summarized really well the discussion that we've had today. I'd like to just add that the World Heart Federation has a air pollution and climate change expert group that's made up of volunteers from around the world, and the role of that group is really to support the advocacy for policy, for implementation, but also to share the research. So if you're interested and want to share the work that you're doing, we'd love to have a conversation with us, with you, so you can come and find us at the booth or here now. But I'd just like to say a big thank you to all the panelists. Certainly a lot of food for thought and things to take away and to act on, which is great. And thank you to all of you for joining us here today. Thank you.